Hello friends, let me at the outset introduce you with the Society for Medical Education, which is situated in New Delhi. Society for Medical Education offers crash courses for clinicians. Most of these crash courses are related to diabetes and hypertension and are all evidence based. The need for these crash courses is very intense for clinical care for primary care physicians in this country because most of the CMEs which we get are either coming through the vested interest group who is having commercial interests in all these courses, or they are available through web from international or foreign organizations and are out of reach for our primary care physicians. Keeping these things in mind, we have developed crash courses in diabetes management and hypertension management. One such course will be presented to you today. What to do when two drugs fail in diabetes treatment? A very appropriate topic and being faced by primary care physicians on day-to-day basis. Let us discuss it through a case. Mr. APJ, who was a branch manager in a nationalized bank, his branch was not showing good results, deposits were not coming, loans not being repaid, and he was under stress. A known diabetic for past 6 years was on oral hypoglycemic agents, and as per his version, he was very well controlled till 6 months back when complete health checkup was done. On a Sunday, he decided to get his blood glucose done, and he found that glucose fasting was 188, postprandial, which is 2 hours after starting a meal, was 312 milligrams. His HbA1c was 9.6 and he got worried and then, of course, rushed to a physician. As per his own version, his blood sugars were always around 110 fasting and around 150 after meals, and he was carrying a self-monitoring blood glucose record diary with him, showing that he was not lying. His HbA1c was 6 months back only was 7.2%, but was from a different lab. Now, practitioners should keep in mind that whenever different labs are used for HbA1c, you may get a wrong notion, because HbA1c is a test that even when it is done with certified machines, with certified procedures, a lab to lab, machine to machine variation will always remain there. So whenever you are trying to serially follow up a particular case for HbA1c, whether declining or increasing, it has to be from the same lab with the same methodology. But 7.2 to 9.6 was a great jump, and he was rightly worried. He was also disturbed because he knew that he has got a very bad family history. His elder brother and his father both died of myocardial infarction in the seventh decade rather. His present kidney function tests were normal. Liver function test was showing SGOT, SGPT raised, but less than 2 times of normal. And this much of rise can be there of non-alcoholic steatohepatitis also, that is fatty liver, you have to keep in mind. His lipid profile was showing typical diabetic dyslipidemia with high triglycerides and low HDL. Triglyceride 150 is the upper limit for males or females for an adult, and HDL cholesterol for a male has to be above 40 mg%, then it becomes protective. But in diabetic dyslipidemia, high triglyceride, low HDL is always a combination which is seen. Other lipid parameters were normal, even LDL-C was 67 milligrams only. Keep in mind also that whenever the LDL is calculated through a Friedewald formula and the triglycerides are high, you will always get LDL cholesterol lower than what it actually is in that patient. So this could be erroneous also. Patient was already on statin therapy. Other important things which could have affected the treatment plan in this particular patient and should always be considered in any patient is age, BMI, waist circumference, which indicates clearly the visceral obesity, and blood pressure 130 by 80 millimeter, but this was with treatment. So all these criteria clearly indicate that we are dealing with a patient in 6th decade, an Indian male, a clear-cut case of metabolic syndrome. But also we have to keep in mind that 2 years back his weight was 80 kilograms and today he is 84 kilograms. So he has gained 4 kilograms of weight. His current treatment was glimepiride with metformin 2 milligram and 850 milligram in one fixed dose combination tablet, one tablet before breakfast and one before dinner. Atorvastatin 20 milligrams. This is intensive statin therapy, probably keeping in view his family history and diabetes. This was written by the previous doctor and rightly written so. 20 milligrams with the dinner. Amlodipine 5 milligrams with olmesartan and hydrochlorothiazide 20 plus 12.5 milligram tablet once daily. He was taking some on-the-counter preparation of vitamin supplements, a very common habit in our patients, and he was thinking that probably vitamins are causing the weight gain, a very wrong notion. Immediate issues which need to be tackled in this particular patient, that the patient was having clearly a sulfonylurea failure and uncontrolled glycemia. We know that diabetes is a progressive disease and beta cell function keeps on declining over the years. We are dealing with a patient who is gaining weight and already obese, predominantly central obesity. Waist circumference beyond 100 centimeters clearly proves this. And he is having dyslipidemia with a bad family history of cardiovascular deaths in the 7th decade. Now this is a very common situation and we keep seeing such patients like APJ on daily basis. But physicians should always recognize that any sulfonylurea tends to fail in 3 to 4 years. 4 to 11% is the failure rate of diabetes therapy on annual basis. Sulfonylureas tend to cause weight. Hypoglycemia induced by sulfonylureas with reflex protective eating by patient is also adding to the weight in kilograms to these patients. Atorvastatin 20 milligram can be a cause of slightly lower HDL. When this is happening in an Indian male, we must have an extreme top priority for cardiovascular death prevention and hyperglycemia prevention or correction in such a patient. Targets were decided and discussed with APJ. Now, unless you discuss out the things with your patients, unless you sit together and decide the intensity of treatment, keeping in view not only the targets but also how fast you are going to achieve them and how these are to be achieved without hindering their lifestyle and their day-to-day activities, unless you do this with your patients, you will not succeed. So you have to sit with the patient and discuss out the targets. So we discussed out the things with our patient APJ and decided to have a reduction in body weight of 4 kilograms, achieving fasting blood glucose 110 and postprandial below 160, achieving HbA1c of 6.5 and also triglycerides less than 150 within 3 months from now. So if possible, we will try to get HDL above 40 milligrams, but we should not be after HDL because none of the trials till this date has proven that with treatment improvement of HDL turns out to good numbers in cardiovascular protection. This has not been shown in any trial. He was told to maintain his blood pressure because the blood pressure medication, because the BP was very well controlled. He told us that he was very choosy about his diet and he was not doing much misadventure with the diet, so counseling was not done in detail. But otherwise, this is another area where one should not forget counseling with the patient. And he agreed to start with 30 minutes regular morning and evening walk, and at least for 5 days a week. So after all these discussions and fixing up the targets and doing the counseling, we decided for the treatment prescription. We should never jump to prescribe a pill unless we are thorough with all these things with our patient. Otherwise, the success rate with the best of the pills will be much lower. This is an evidence based statement. We discussed option 1 with him, increasing glimepiride and metformin, because glimepiride 4 milligrams and metformin total 1700 milligram was all he was getting. This is the commonest way and the easiest approach. Every primary care physician loves to do this, but I will show you how this is going to be a futile exercise. Because out of the maximum possible insulin secretory capabilities of any sulfonylureas, we get 85 to 90% of the action at half the recommended dose. That means the maximum dose recommended for glimepiride is 8 milligrams. 85 to 90% of the action possible with glimepiride is already there in this patient who is consuming 4 milligrams, which is 50% of the 8 milligrams. So if you increase the dose further, you may not get any further substantial improvements in glycemia, because glycemic correction, if at all some improvement will happen, that will not stay longer than 4 or 5 months. So it is futile to even think that by increasing the dose to 6 or 8 milligrams will achieve anything substantial. Another important thing is that if you increase the metformin from 1700 to 2000, this will be a welcome step, but nothing substantial will add to the glycemic correction. So option 1 is waste of time, waste of money, waste of effort, and you are exposing the patient to further failure. And of course, this plan is going to be detrimental for the body, who is already exposed to inflammatory milieu inside, hyperglycemia, and you are already also exposing beta cells to fail further by increasing the doses. Now, to know more on all available options which we discussed and what we finally did to this patient, our APJ, how much we succeeded and what at all finally came out, and to have a face-to-face discussion with us, to interact with the faculty, in the end, in the conclusion phase, you must join a crash course with Society for Medical Education. So I invite you to join crash courses with Society for Medical Education. Just write an email to drrklalwani@yahoo.com, drrklalwani@yahoo.com. Thank you very much for patient listening. This is Dr. R.K. Lalwani addressing you from the platform of Society for Medical Education, New Delhi. Thank you once again.